So without further ado, I want to introduce Dr. Mira Maximos. She is an antimicrobial stewardship pharmacist in Ontario. And so today she will be covering this journal club on antimicrobial use in palliative care. So I'll pass it over to you, Mira.
Thanks, Ali. Okay, so we're going to talk about considering antimicrobial stewardship in palliative care. And really, palliative care is a very broad term. So most of us will focus at end of life care, but there are a few questions for us to consider. Before we get started, I do have a few disclosures to share. And this talk hasn't received any financial or in-kind support. So I'm doing this for fun. And the land acknowledgement for me. So I'm joining you from the traditional and unceded territory of the Anishinaabe, Haudenosaunee, Lenape, and Chinook nations. So the learning objectives for today, we're going to briefly discuss, and I say very briefly because it's a growing area of information, some of the knowledge on antimicrobial stewardship and antimicrobial use at the end of life. And antimicrobial use is more going to focus on what are we seeing with respect to trends? So epidemiologically, what's going on? And then the stewardship is what initiatives have been done and what have they resulted in. Then we're going to review and critically appraise one of the papers by Lopez et al. That looked at use of antimicrobials at end of life. And then we're going to have an open discussion. However, you can ask questions or pose any thoughts or ideas at any time, so it doesn't have to wait till the end. But if we get to the end and nobody's asked any questions, we'll have an open discussion about ASP and palliative care. And I just want to see if we can learn from each other's experiences. So the first broad area that we're going to talk about is antimicrobial stewardship and use in palliative and end-of-life care. Before we do that, I think posing a few questions is very important. So the first one is, what is the goal of antimicrobial therapy? Well, the goal is to reduce burden of disease, cure an infection, and improve patients' quality of life and survival. So we are treating an infection. Now, what happens when we move that question a bit further and say, what's the goal of antimicrobial therapy in palliative care? That doesn't necessarily change the question that we just asked, right? Because a patient that's receiving palliative care, it could be, for example, a patient receiving palliative chemotherapy that has a very actually significant months or years of life left, but we know that they may have reached a state where their disease is incurable, or it could be a COPD patient receiving palliative care that has COPD, for example, again, an incurable disease, but receiving care. So in this definition, palliative care can be involved earlier on in the disease process before end of life. So again, here, the goal of antimicrobial therapy could predominantly still be treatment and cure of a disease, an infectious disease. Now, the next question is where it becomes a little more gray. What is the goal of antimicrobial therapy in end-of-life care? And really, end of life focuses mostly on the last days to weeks of life. And here, predominantly, when you look at if you've ever been involved with goals of care discussion or have seen goals of care plans, here you're looking mostly at improving quality of life, providing comfort, and for some patients, depending on their preferences and what it is that they want, it could be extending life. So goals of antimicrobial therapy at end of life really take a very different approach. So I'm going to go through a few different studies. The first one is a systematic review from 2013, and it looked at antimicrobial use for symptom management in palliative care. And when I say symptom management here, we're speaking to things like, having urinary burning, like urinary tract burning, or having respiratory issues with respect to dyspnea. So symptoms that you would potentially see in infection and at end of life. It included 11 studies with prevalence of antimicrobials for only prevalence of antimicrobials ranging from 4 to 84% in the different studies. So it's a huge range. And only 8 of the 11 studies provided some sort of response with respect to symptom measure. The methods they used were very variable, not necessarily standardized. And the notation in this systematic review was that patients with UTIs seemed to have the most improvement in symptoms. But again, this is variable, and that's probably why they only were able to conduct a systematic review, not necessarily a meta-analysis. So this study was published earlier this year, and it looked at patients in Singapore that were receiving antimicrobials in the last 24 hours, in the last few weeks of life. And the reason they conducted the study was 45% of hospitalized terminally ill patients in Singapore actually received antibiotics or antimicrobials in the last day of life to either prolong survival or relieve symptoms. So what they wanted to see is if they could conduct a study to understand the antimicrobial use and what it actually impacted at end of life. So this was a cohort study. It was a retrospective study, and it was conducted to evaluate the impact of ASP interventions on the use of broad spectrum antibiotics. And here they looked at things like safety. So did it increase the risk of things like mortality? And did it impact the length of stay or any other patient-related outcomes, patient-focused outcomes? And they found that antimicrobial stewardship initiatives reduced things like time to discharge for end-of-life period. So patients were able to, if they wanted to, go home and palliate at home. And it didn't have a negative impact on safety. There was another study that was published in 2015, and this was not really clinical trials, more of a viewpoint article. And a few really interesting points came from it. And this is predominantly in the US. But I mean, I feel like this data could be extrapolated to many European countries. I'm not entirely sure if we could extrapolate it elsewhere. I think I'd have to look more further at the data worldwide. But they found that 90% of hospitalized patients with advanced cancer received antimicrobials at end of life. And 42% at least of nursing home residents with advanced dementia received antimicrobials within 2 weeks at end of life. 25% of patients in hospice received antimicrobials at end of life. So it's actually quite a significant proportion of people at end of life that receive antimicrobials. So when you think about getting an antibiotic, and here we're looking at what happens, what are the potential adverse outcomes at receiving an antibiotic at end of life. So, I mean, there may be less focus on things like resistance to antimicrobials if the patient is not going to survive for a prolonged period of time. However, that's not the only focus of stewardship initiatives. And that's not the only focus that we should have with respect to antimicrobial use at end of life. There are a myriad of drug-drug interactions. Clostridioides difficile infection at end of life would be quite a challenge. Acute kidney injury with some agents or other organ damage. Certainly many antibiotics cause quite a bit of GI upset and other side effects. And then potential for adverse drug reactions or adverse events related to allergies, depending on patient's allergy history. Then also there's the human factor of, you need IV access, blood work, chest x-rays, catheterization. So we have to take into consideration the patient's wishes, the patient's goals, and the patient's plans, and weigh them along with the family and other care providers and your care team against these potential adverse outcomes. And I'm sure many of us can think of more as time goes on too. So really, the question is, what are the potential benefits of using antimicrobials at end of life? Potentially prolonged survival, but how much and what data is available on that? And then the other question is, could antibiotics, antimicrobials, be used to improve symptoms or for symptom relief? If a patient has a symptomatic urinary tract infection, for example, and is incredibly uncomfortable, is that something that could be worked into a goals of care plan? So we're going to move into the study for tonight, but before we do that, I want to see if anyone has comments or thoughts about what I've said so far.
I would add maybe a potential benefit that not listed. It's kind of a quote unquote potential benefit would be you're treating the family.
Yep. Yes.
Psychological, I guess, and not so much any benefit for the patient.
Yes, that's very fair. And I think that's a very, very good point. And that's why it's so important. I think this is where stewardship becomes potentially a really good interlay between, you've got your palliative care team and your stewardship team. Could they work on initiatives together to discuss goals of to include antimicrobial use in the goals of care plan at end of life, in palliative care before patients reach end of life, so that decisions can be made with more of a less, it's always going to be emotional, but less emotional constraint that comes with end of life. That's a really good point, Travis. So the study overview and methods, I'm going to click, there we go. The study is a retrospective study that is intended to analyze a lack of symptom benefit with antimicrobials at end of life. So here, really their hypothesis was that antimicrobials at end of life would not have benefit. So it was a negative hypothesis. This was a really interesting study. It was conducted in it was actually conducted in 2017, but published in 2021. Apologies, I'm not really clicking in the right places. So it is a cohort study, like I suspect many of these studies will be. There's a retrospective chart review. It looked at antimicrobial use at end of life with the primary outcome of assessing frequency of symptom occurrence. We'll get into some of the limitations in a little bit, but the hypothesis, like I stated, was looking at antibiotics at end of life, using antibiotics at end of life would not alter symptom occurrence. So this was actually, I'd never heard of the term quaternary care academic hospital, but I guess it's more of like a subspecialization beyond tertiary care. So it's more of a palliative care unit. I think in Canada, we have more hospice type centers. So I wonder if that's similar. It's a 766 bed quaternary care academic hospital in New York. Patients were diagnosed with an infection and would, in order to be included, they would have had to have passed away within 14 days of their admission. And this study was conducted within a 7-month period in 2017. So again, that primary outcome was symptom occurrence. The secondary outcome was looking for information that included documentation supporting the need for antimicrobial therapy and evidence of goals of care discussions for antimicrobials at end of life. So was that included anywhere? And if so, how much of the information was included? They don't really mention much in the way of, sorry, I'm allergic to my dog and she sheds a lot in the spring, so I'm kind of congested. So with respect to what they included, they didn't include thematic analysis of the type of information. So it didn't really include a qualitative component. It was mostly descriptive analysis, and some quantitative information looking at their primary outcome. So the only exclusion criteria mentioned really was lack of infectious illness diagnosis, which is reasonable. So what was collected? They looked at demographics, different data points for clinical data, lab values, goals of care, family meetings that involve antimicrobial discussions, whether symptom information was included, vitals, length of stay, and antimicrobials that were prescribed. I had never heard of Jamovi, but I guess it's more of like an Excel type of interface that connects with R. So they used Jamovi and interfaced it with R in order to do their statistical calculations. So for all their descriptive statistics, for frequencies of categorical ordinal data, that's what they use. Means and standardized deviations for continuous data were provided. Side note, whenever I see a mean, I'm always a little leery because if the data is skewed at all, sometimes I wonder if medians could be better. However, they're using parametric statistics, so I suspect that they took a look to see, with respect to heteroscedasticity, I can never say that word the first time around, they probably looked to see that this was actually appropriate. And then the outcomes were compared between the two groups. So those who received antibiotics, which I'm going to term plus AB, I think in the study they did AB plus, and those who did not, which is negative AB. And they looked at significance being a p-value less than 0.05. If data was categorical, they used the chi-square test. And if it was continuous, they used Van-Whitney U or Fisher's exact test. With respect to the results, the first thing that we always look at is table 1, so your demographics table. For those that actually received antimicrobials, it was about 90 patients, and those that did not were 43. So that's an important aspect to me from the get-go. So the majority of patients did receive antimicrobials. With respect to sex disaggregation, 50% were female, 50% were male in the antimicrobial receiving group. However, it was different in the group that did not receive antimicrobials. More were female that did not versus male. They don't really provide much in the way of explanation for whether it was more elderly females or younger males that did not or did receive antimicrobials. So that's something I would have very much liked to see. The age groupings, certainly I think that some of this could potentially be more predictable. So younger patients were more likely, according to the study, to receive antimicrobials than older patients. And for this study, it was predominantly Caucasian patients, and more patients received antimicrobials than those that did not, that were Caucasian. That varied slightly by a different race. However, I think that the numbers here are so small, it's really challenging to make much of an interpretation for other populations. And also religion potentially seemed to impact or play a part in whether or not patients felt that antibiotics were appropriate and end of life, or could have been completely unrelated. Again, with these small data sets and cohort studies, it's challenging to know how much this plays into something. So really, before I move on, it looks like age was one of the biggest predictors of whether patients would receive antimicrobials or not. And I think that that is an important piece of information for us to consider as stewards when we're approaching talks about antimicrobials at end of life. So really what ended up happening was there were 295 patients that were admitted during this period to the PCU. Of these, 133 met the inclusion criteria. 90 of these patients, so 68%, received antibiotics or12%, and 43 did not. That should be a negative, not an equal. Apologies. Only 12% of those that received an antimicrobial had an indication documented. I mean, like documented anywhere, not necessarily cultures or whatnot, just an indication, which I mean, I think is probably representative of what we see, but kind of disheartening because we should have a better idea of why we're using antimicrobials. The most common symptoms within 3 days of end of life were dyspnea, lethargy, altered mental status, obtundation, and or pain. So those were the symptoms that patients were experiencing. And what surprised me in here was um, urinary discomfort, which is most common reason why I think in my practice individuals may receive antimicrobials, wasn't in here. Altered mental status is also very challenging in this population. I think somebody unmuted their mic. I don't know if you wanted to say something. Nope, maybe not. Apologies. Sorry. um, Sorry, yeah. So altered mental status is a bit more challenging, right? So if you have a patient who comes in and is delirious for whatever reason, but is at end of life, is it related to the disease or is it related to an infection, related to something else? So a lot of this I can understand clinically is very, very challenging to determine what to do. So I think this is why that goals of care planning earlier on, if you come in and you have an altered mental status, you have days to live, what would be your preference for how you would want to approach antimicrobial antibiotics at this point, knowing these potential adverse effects? How would we approach this? And about 72% of the charts had a documented goals of care plan, but absolutely none whatsoever contained a preference for antimicrobials. So this is probably one of those things we could build into order sets, build into different frameworks where we're actually looking at creating goals of care plans and looking at antimicrobial use at end of life. There were, I guess they're called MOLST or most, 12% of medical orders for life-sustaining treatment forms documented short trials of antimicrobials, but the converse would be 88% of the chart, any documentation for the reason to antimicrobials. And we talked about that a tad bit earlier. So really, if we can work on those two factors of including in the goals of care plan and then speaking to why it is we're using antimicrobials, that may improve antimicrobial use at end of life. Here's the part that may not have shocked me, but still shocked me. What antimicrobials were actually prescribed? The majority were Vanco, Pip/Taz, and ceftriaxone. I think that gave me pause because vancomycin at end of life, are we measuring levels? Are we monitoring renal function? Are we using Vanco and Pip/Taz together? Because that's more so nephrotoxic. This is something that I think as we become more comfortable as stewards, we'll be able to speak to a bit more, and how sometimes these antimicrobials aren't necessarily as non-noxious as individuals might think they are, particularly when somebody is very frail. So they looked at a few different outcomes like we spoke about a little bit earlier. So they collected data for laboratory results, for vital signs, documentation, symptoms, length of stay, a whole bunch of different pieces of information. And really, no one at all, none of these parameters was statistically significant between the two groups. And that's really important because there might be trends. And mind you, this is a very small cohort. So they don't really discuss what the power calculation was that went into this, or even if they had one. They predominantly looked at things more of a descriptive statistics. So the p-value, I'm not entirely sure what the sample size population was that they had to meet. So this is important. So far, it looks like the groups are relatively balanced between the lab parameters and whether they received antimicrobials or not. So really is the focus on, do we focus more on education of the clinicians, patients, and their caregivers? Or is there a way to help understand which populations would most benefit from antimicrobials at end of life? So they do provide a quick summary, and really my summary of their summary is that antimicrobials at end of life didn't really appear to alter symptoms. They also said that there was no difference between the groups for any of the markers that they followed. there were limitations that they also felt related to their study, and I added a few that I thought of as well. It is retrospective. So when you have a retrospective chart review, it's a cohort study. You cannot infer causation. Best you can do is be able to speak to correlation. And that's not necessarily a bad thing. It just means that we need to know the extent to which we can make decisions based on a study. And really, this relies on what's documented. So it's uncertain what details led to decisions regarding, antimicrobial use, regarding why did they use vancomycin? Maybe there was MRSA in the blood, who knows? And if so, then why is there such a significant proportion of requirement for MRSA? So a lot of those details were unknown or not collected by the researchers in order to share with us. And there wasn't really a supplement for me to review. Symptom severity wasn't discussed, and this was a moderate sample size, so it wasn't a large population. I also wasn't entirely sure how they did their sample size calculation. And this is a specialized quaternary care center, which isn't common. So a lot of the times when we're thinking about implementation of stewardship, it'll be in, end-of-life care can happen in an ICU, on a medicine ward, surgical ward. There are many, many places where end-of-life care planning would occur. So would that need to shift a little bit, the considerations for different populations? Absolutely. But what surprised me is a specialized center didn't have those thought processes in place prior to reaching end-of-life care, which maybe we should consider doing that, or they would probably consider doing that. So what are some of the directions that could be taken? And I'm sure there will be more from everybody participating tonight. So I think considerations for prospective quasi-experimental studies. So things like, pre-post analyses or interrupted time series. I suspect that it'll be very challenging to do more of a randomized trial. So a prospective quasi-experimental study would be reasonable to look at implementation of antimicrobial discussions into goals of care in the palliative care planning. So is this when palliative care becomes consulted? Does that discussion happen this early? And then can we look at over time? Do we follow these patients over time until they reach end of life and see about antimicrobial prescribing? Also, involvement of antimicrobial stewardship teams in palliative care rounding. That might be a way to start introducing the thoughts, the questions earlier on and into more of the day-to-day thought process of the clinicians. And that might help improve antimicrobial prescribing or use as it reaches, their thought process, like right at the beginning. If I'm always rounding with a team, they start to think, well, this is what we talked about last time. I wonder if this applies to this patient case too. And we need to continue to grow our understanding of what benefits, if any, antimicrobials provide at end of life. So it's not one of those scenarios where, we don't use antimicrobials at end of life. We have to figure out who it would be appropriate and how do we determine that? How do we make that decision cohesively as a care team, but including patient's family, the patient themselves, when they're able to make decisions, your stewardship pharmacist, your clinicians, everybody, and the nurse certainly, because they know the patient very well, everyone involved in the patient's care. And how do we structure concepts around antimicrobial overuse and unnecessary use into shared decision making? So how do we share that type of information? So that's really what I have. And that third part of the discussion for tonight was to stop here and ask, what are your thoughts on these directions? And what have you seen? And have you done antimicrobial stewardship and palliative care at your centers?
I'll take a quick moment to also welcome Dr. Deb Harold into the Journal Club. I know you joined us a little bit late, but here's everyone. Dr. Harold, I believe you work in Ontario, also in hospice care as well.
You're a perfect person to help.
Not to put you on the line, maybe someone else. Hi, Kelsey.
I don't know if anybody has implemented ASP into or antimicrobial use evaluations into palliative care, because I know I've certainly been thinking about it and how to approach it. This is a good way for me to start thinking about it.
Hey, Mira, that was a really good talk. I really appreciate it. We haven't done that in our center, but I know like that the IDSA guidelines on antimicrobial stewardship did add that into their most recent version on antimicrobial stewardship about the importance of antimicrobial stewardship when it comes to patients who are palliative or terminally ill. So I think it's definitely worth thinking about. I have had a few cases just when I've been on service where one patient had persistent MRSA bacteremia with CNS emboli and endocarditis and just overall poor prognosis. And so they were planning on withdrawing care, but they were continuing medications until family could arrive in order to say their goodbyes and then withdraw care. So they continued the patient on vancomycin, but weren't monitoring levels. And so you do have to wonder, could you be potentially doing more harm than good? And it's not necessarily the antimicrobials or like a failure or a bug drug issue. It's more maybe more just the underlying diagnosis and disease that's caused such destruction. So I think it's definitely worth having these discussions. And I think that type of collaborative approach where antimicrobial stewardship is invited to the table to have these kind of face-to-face discussions would be a more effective strategy than simply writing a note in the chart, because I think there's a lot of emotion in some of these cases.
No, I agree 100%. And like, even as you were saying that, I'm sitting there going, septic emboli to the brain, vancomycin is a big molecule. How's that getting in? What's going on over here?
Yeah.
Like, absolutely. And I think even in the way of stewardship, like, could something like linezolid have been more appropriate? Because certainly it's more static, not cidal, but what are we trying to achieve? That's a really good point in waiting for a patient's family to arrive. It's hard because people think that antibiotics, I don't know if they think that, but perceive antibiotics to be what's holding the patient stably or stable, like holding them together. And that's not necessarily true, right? That patient is still having those, the disease process that is bringing them to end of life too. But yeah, it's hard. Like, at what point do we remove different treatments? And if the patient passes before family comes, the ethics and moral component of that too. It's a good point.
It's Andrea from Nova Scotia here, late here, but want to thank you for the for this review. And it is something I have struggled with at times, working both in palliative and in antimicrobial stewardship. I think the point you bring up of like collaborating and bringing in goals of care, I think are great ideas. It might be something that we want to look at here in Nova Scotia. But I thought it interesting at the very start when you were showing like the differences and the percentage of patients, not in the actual study, but I think it was in your slides before, but like 90% of hospitalized patients, but 25% in hospice care. And I wonder if, like if there's something to be said there about understanding of palliative and goals of care. And, when we put them into an acute care setting, do we approach it differently?
I think that that's a really good point. I think what even surprised me is that a quarter of the patients in hospice, and hospice is the very last few days of life. Even a quarter of patients were receiving antimicrobials at end of life. Um, and it makes me wonder, okay, so was this antimicrobials to improve quality of life? Do we have that data? Do we know if it's improving quality of life? And is there a standardized way to look at this? So I did so for my master's, I did a randomized trial looking at the use of a picture-based medication tool to improve antiemetic use, right? And we used a standardized way of looking, like a Likert scale. Patients would tell you where their symptom score is. But is that something that is being used? Or how do we standardize patients' symptoms when they are very variable? Do we look at them like, if it's a dyspnea, what is your severity of dyspnea from a scale of 0 to 10? Are patients able to give us that information? Or are we looking at things like a grimace? Are they more comfortable? Are they less comfortable? So I think even the parameters for how we assess efficacy or appropriateness are variable too. And yeah, certainly when I was looking at this, I'm like, okay, so a lot of patients that are hospitalized with advanced cancers certainly will get antimicrobials. And I'm thinking, even just amidst the pandemic, how many more patients come in with more of an advanced cancer diagnosis that weren't necessarily aware of. And many of them do come in with, a secondary source of infection along with their cancer too. So yeah, it's. I don't know if this extrapolates to Canada or other countries either. So I wonder if anybody has a lot of experience in antimicrobial use in different settings and what they see. Because I work in a small community hospital, I see a lot of it.
Hi, it's Deb Harrell from Ontario.
Hello.
I just think I think it's a very interesting idea. I'm not an antimicrobial steward, so I'm sorry, I'm ignorant from that side of things. I'm probably the prescriber that you're trying to change. But from a palliative care point of view, that's what I specialize in. And I mean, in Ontario, at least, hospice care can be 3 months long. It's not just days. So when we see somebody like 25% of hospice patients, I'm not sure what the longevity of those people were. The other thing is like the first stat of 90% of hospitalized patients with advanced cancer receive antimicrobial at end of life. I'm not sure what the definition of end of life was there either. Some of my palliative patients that I care for and would be admitted under palliative care order sets or palliative goals of care may live a year. And so I think much of that article I appreciated, and it makes me think about why do I do the things I do? Why do I prescribe the drugs? And at least documenting a better idea of I prescribe that to try to overcome an illness and therefore prolong life, or I prescribe that antibiotic to manage a symptom set based on the goals of care of the patient to improve a suffering symptom. And I think that's very worthwhile to really ask us to document why are we doing this, and therefore at least be able to look back in chart reviews or other sort of research methodology to see whether it was effective or not. The point I guess I would make, and even thinking about the patients I saw today in the hospital, much of the time managing patients with palliative diagnoses approaching end of life is we never know they're at the end of life until retrospectively we can look back 14 days from death. And so it's really hard to know. I mean, I've got a metastatic prostate CA man with advanced dementia admitted to hospital with falls and a pneumonia, and he's on antibiotics. Is that wrong? I don't think so. I think if I manage his pneumonia and he survives, he'll go back home and die at home where he wants to with his wife. If he doesn't survive, then he's going to be a negative stat for this kind of research, right? That I treated him with an antibiotic as he was approaching dying from metastatic prostate cancer, maybe, but a complicated, very complicated story. So It's really hard to know until after the fact that, oh, you were actually in their last illness,
Mhm.
and maybe treating with antibiotics at that time was inappropriate.
That's a really good point. And you're right. End of life certainly does extend beyond the days, 2 weeks. I think when I think of end of life, and this is, I'm not a palliative care specialist at all. My area of specialty is ASPID. I think of when nurses start to speak to a PPS of like 30 or 20. So patients have stopped eating or drinking, and now they're, they're, the disease itself has led to this progression. But you're right. If in this case though, like I think in the study we looked at, only 12% of the patients had some sort of diagnosis associated with the antimicrobial. So even just stopping to think, why am I using this antibiotic, will make a huge difference. Because if we don't have a good, clear reason, I think that's a really good marker for why are we even doing this. And that might just be like the start of something really good.
I agree with that. And that's what I took from that article, is
Mhm.
asking myself why and documenting the why, right? Why did I choose this? How did I communicate that? What is the expectation of using this medication? I think that's very wise
Mhm.
to start really asking us, not just blanket, hopeful prescribing without any sense of a real outcome.
Yeah. And I think that that's more than enough. It's really hard. Like as a stewardship pharmacist, you're coming in to tell a clinician or speak to a clinician, so there's a urine culture, but is the patient symptomatic? And it's hard. Like, is the patient symptomatic? Do we know if they're symptomatic? Can they tell us if they're symptomatic? And, you're the clinician who's been taking care of this patient for so long. You know them much better than I ever could. So I think that asking these questions, like I think that this has to be more of a relationship, like the stewardship pharmacist kind of learning from the palliative care team and vice versa would be the best way to do it. I think you're giving me ideas for how to run a study too, so that's wonderful.
And from the symptom severity point of view, you need a patient who is able to communicate in some way, but the ESAS score is really the
Yep.
only way that we manage severity of symptoms
Yep.
on a Likert scale.
Thank you. That was a word. I was like, I can't remember what it's called. The Edmonton
ESAS,
symptom
yeah, that's
assessment.
Canadian, Edmonton.
Yes. I was like, I know that there's a name for it, but it's a Likert scale. I don't know if anybody else has any experience or any other thoughts.
So I have a little bias here because I dislike vancomycin a lot, and
We all do.
we tried to never use it, but it's taken me 3 years to get physicians to stop using Vanco and use Zyvox or Dapto primarily. We finally got like Vanco below those for days of therapy. But from my perspective, a lot of things you're talking about, kind of like a gray area, like who needs to be on antibiotics, like we can talk about a lot of different patients individually, and some do and some don't. It's kind of difficult. For me, from an ASP perspective, looking at the data, it looks like we're choosing the wrong antibiotics though.
Mhm, mhm, mhm,
Like honestly, like if you look at this slide right now, a nursing home patient, 90% with advanced cancer, then the 25% end of life, and 40% of them are getting Vanco. I think that's completely wrong. We could debate whether Zosyn or cefepime. Even then, we're, like if you want to look at C. diff, anything like that, and you have like the tetracyclines or ribociclib or something like that, it seems more like, it's going to be hard to convince somebody not to do antibiotics at end of life care, but we should be maybe educating more on safer and just as good, if not better, alternatives for these
mhm.
patients. And,
Yeah.
part of that is ASP for years until a couple years ago, we wanted Vanco because it was our cheap MRSA agent. Zyvox is expensive. Dapto was expensive. I mean, I don't know in Canada what it is for you guys now, but for us,
They're
Zyvox
probably
and
all more
Dapto
expensive.
Dapto and Vanco are pretty much equivalent, and Zyvox is cheaper than Vanco.
Zyvox, is that linezolid?
Yeah, linazolid. Sorry, I go back and forth and say whatever one's easier for me to say. linezolid is, for us PO, it's like about $3 a day.
Okay. I think
Um,
the price did change for us recently.
So there's just things like that. Like maybe we're not, I mean, we could probably do a whole offshoot on altered mental status, UTIs, symptoms, asymptomatic UTI, whatever. That's probably a whole nother topic, but
Yeah.
Even before that, I think maybe you should, I mean, for me personally, I think maybe talk about or address what antibiotics are used, and what should be maybe option 1, 2, and 3 before you get to some of these other options.
That's a really good point. I think the Vanco and I have problems. We always do. Vanco and aminoglycosides, it's just a thing. But I think about things like, okay, so doxycycline I use, and I suggest a lot for COPD exacerbations, but many of these patients may not be able to swallow well or be able to sit up. So you're going to get you're going to possibly worsen what's happening by causing GI irritation. So, I mean, we have our stewardship hat that certainly we have drugs that we know are our go-to drugs, like doxycycline seems to be a stewardship go-to, but it is balanced against the other side of it. Like, I think I would be more apt to suggest something like ceftriaxone if oral intake has significantly reduced, certainly over Taz or Vanco. But then I've seen these cases where you have a patient who has an Enterobacter in the urine. And then what do you do? So you have, I mean, at least for us, we have very limited options. So you've got your Cipro, you've got your Meropenem, you've got your Ceftra, and then you've got potentially aminoglycoside. I'm like, yeah, we're not doing that one.
I don't know. I think you're dismissing the 5 milligrams per kilo times 1 aminoglycoside for those types of patients. The IVIM, and then then they don't have to take, you don't have to give them an IV line, you don't have to give them PO, and times 1. And I mean, I'm not a big prolonged aminoglycosides, but the times 1 data, granted it's a little bit older, but it's pretty safe. And these patients, obviously, you're not going to be worried a ton about the hearing loss and stuff like that. It's more of like comfort care, and this quality of life. And I think aminoglycosides are still, especially the times 1, are still a great option.
I think it's a good point to consider. I know that there was a recent study that found that you could still have nephrotoxicity with single doses. I'll have to pull it up, but that caught me by surprise, to be honest. But yes, at times 1 doses certainly are reasonable. I don't really know if a lot, and I mean, this is just my practice and around me in Ontario, there aren't a lot of pharmacists that are necessarily as comfortable with aminoglycosides where we are. So that may be just more of a learning curve for us. And is a times 1 dose better than doing Meropenem times 5 days? Absolutely. But how do we get past that? How do we get that learning? Like we're learning too at the same time.
Yeah, and that's, I think, the biggest obstacle, and I guess why we're all probably here with Firstline, is trying to overcome that obstacle with educating everyone in your facility in an easy way. So, I mean, we've slowly we deal with a lot of the nursing home residents and ESBLs, quote unquote UTIs and all that stuff, and how do we treat them, and whether you can give them no oral options, and how you handle those people from then. And so we've been slowly kind of picking up on the IM gent, and anecdotally with decent experience, but it takes a lot of time. And like you said, it's really hard to get people to change their ways, especially when they're used to, from looks like here, you just click vancomycin on the chart, right? And then you just send them from the ED on vancomycin, and then it just kind of gets continued because it's just what happens.
And it's terrifying. Like when I think, like, okay, Taz on its own, I'm like, okay, all right, okay, we can do this. Yeah, and I make myself like, okay, our kidneys are going to have problems. We are not going to do all right here. And I think at that point, you're really looking at so much more toxicity. But you're right. I think maybe the stewardship aspect it's that trust building, right? You're building a relationship with the clinicians you work with. So starting by building trust in, can we ask why, but not necessarily in a manner that is intrusive. And then can we narrow down the therapy? Can we focus more on agents that would reduce the risk of causing harm? And then work from there, because I think this would be a journey. Like, this isn't something that would be a few months. I think this would be a few years in the making to do. Thank you, Travis. Those were really good points.
Mira, if you find that article on the aminoglycosides,
I'll find it.
share that with everyone.
It gave me pause. I will.
I know also there was just a recent review article on it, and pretty much the rate of nephrotoxicity and ototoxicity with the one time was really, really low. I mean, it's meta-analysis that was just done.
Let me see what I can find. I don't know if I was reading it really late and my brain didn't register it properly, but I don't remember much about it. All I remember was going, oh, that's not good.
Well, I want to be mindful of everyone's time. So was there any main questions or anything left over for anyone? Well, I think the aminoglycoside conversation, that might be something that we can keep going on in the community. Since we're all there, we can kind of post and share there. And I just want to thank Mira again for putting on this presentation and leading the discussion. And it was really nice to see all these people from different areas, like both in Canada and the US, to come together and have these discussions. And that was really awesome.
Thank you, everyone.
Thank you.